Good afternoon, doctor. Our patient that we are visiting with today is Sharon Anderson, a 66-year-old African American female. She came in due to recent issues she has been experiencing since she regained consciousness after having a stroke. She has had double and blurring vision and has been wearing an eye patch over one eye to relieve the doubling while alternating every so often. She experiences dizziness when moving and is uncomfortable when she sees movement in her peripheral vision. She has a history of hypertension and the cerebrovascular accident that I mentioned. She has a family history of cataracts and possibly glaucoma, but no history of diabetes, cancer, inflammatory conditions, or blindness. As far as the acuity findings go, at distance we were able to get 20/30 minus 2 OD, 20/40 plus 1 OS, and 20/30 minus 2 OU. We then moved on to chair skills and we started with cover test at distance, and we found that she was a 4 prism diopter right hypertrope, and then at near she was a 10 prism diopter X of 4 with 8 prism diopter right hypertropia. For visual fields OD, she was full to nasal and temporal, full superior, but restricted to 75% past midline in the inferior. She was full for OS, but she experienced pain in her right eye and upgaze and also diplopia. During pursuits, she was jerky with multiple losses of fixation and also experienced dizziness, which improved with the application of binasal sector occlusion. During near point of convergence, she was unable to make single through habitual, so we put 4 prism diopter base down over the right eye, and she broke at 10 centimeters and recovered at 15 centimeters. Confrontational fields were full to finger count, OD and OS. Pupils were 5 millimeters to 3 millimeters OD and OS, and pupils were equal, round, and reactive to light and accommodation without any signs of APD. Retinoscopy, she was plano through her habitual prescription. And then for the medical findings, the agnexa was clean. The lids and lashes, there was no debris, but there was signs of meibomian gland stasis. The tear breakup time for the tear film was about 5 seconds. The conjunctiva had a trace injection. The sclera was white and quiet, OD and OS. The cornea was clear without any edema in both eyes. The iris was flat and hazel. Pupils were normal. The angle through von Herrick was 3N, 3T, both OD and OS. The anterior chamber for both eyes was deep without any signs of cells or flare. The lens in both eyes did have a trace of nuclear sclerosis, and pressures in OD were 16 while they were 17 in OS. In the posterior segment, the vitreous was clear. The optic nerve was round, pink, and distinct, with 0.5 horizontal and 0.45 vertical CD ratio. The macula was flat and intact, OD and OS. The vessels were 0.6 AV ratio, OD and OS, without any attenuation, but there was trace copper wire appearance. Posterior pole was unremarkable. In the periphery, there's no holes, tears, or breaks. No signs of neovascularization, scarring, or other pigment changes, and that is in both eyes. I would like to call over to the audiologist's office here in town. The results collected indicate that she may be having a vestibular issues with signs and symptoms of vertigo. I make this claim due to a self-report of dizziness when moving and seeing blur and double simultaneously. During the exam procedure, we also saw her struggle with fixation during near point of convergence in smooth pursuits, and couldn't follow the target without air during the latter of the two. I would like for the Dix-Hauppike maneuver to be performed on this mutual patient to verify the suggested diagnosis of vertigo. Once this issue has been cleared, I would like to see this patient back for a follow-up appointment in which we can recheck chair skills and acuities. Thank you.